Hello and good morning, ladies and gentlemen. It's actually great to see so many of you here, and I can still see people coming in. So please do join us and grab a seat as quickly as you can. I thank you all for making it on time. I know some of you were at the plenary, so we really do appreciate your presence because this panel session, I believe, is really, really very important, particularly if one bears in mind that the context for this entire conference really is it's all about how we get to a place where all of the world's people are covered by universal healthcare systems. And as you will see, the private sector, which is what we are addressing, and the role of the private sector in delivering UHC, and I think we're going to allow ourselves from time to time to use that acronym, the role of the private sector is going to be fundamentally important, as you all know. Oh, and by the way, everybody, for those of you who are wondering who the heck I am, I'm Stephen Sacker, and many of you who are WISH regulars will now recognize me, and I also perhaps am recognizable to some because I work for the BBC and I do interviews on the BBC, which means I can ask some tough questions of this lot because I have license to be grumpy. So that's good. But getting back to the subject, we know that the World Health Assembly has set this really ambitious target of getting 1 billion more people covered by universal health care over the next 5 years. I mean, that is an extraordinary ambition, and to make it happen, there is no question that the private health sector is going to have to be woven in to national health networks all over the world. I think, and I've got experts here, so I'm a little wary about saying too much, but I think it's true to say that well over half of the healthcare delivered around the world today is actually from private health companies, institutions of one sort or another. So private healthcare is providing healthcare to many, many people around the world already. And in so many countries, not my own, Great Britain, where of course we have the tradition of the National Health Service established right after the Second World War, but in so many countries, they are reliant on private sector healthcare for much of the healthcare that exists in their countries. I mean, one example that sticks in my mind, India, where I believe 80% of the healthcare that is currently provided in India comes from the private sector. So thinking that you can establish UHC and leave the private sector out of it is clearly unrealistic. But the question is how it's done, how to establish really successful, efficient working relationships between the public sector, between governments and the private sector, so that there is a mutual trust rather than mutual suspicion, there is shared objectives, and there is institutionalized cooperation at every level. That's the challenge, and that's what we're going to discuss with our panel. Let me introduce you to them all, and then we'll get business underway as quickly as we possibly can. So all of you, I hope, perhaps already have or are going to get a copy of this report. As you know, months and months are spent by experts putting these reports together. This one is the role of private providers in delivering universal health. I see they say coverage, not care, but whichever you want to use. So this is the report. It's extraordinarily important, I think, that you all read it because it's full of fascinating sort of observations about the way things are now, but also, perhaps more importantly, some real concrete proposals as to how this subject is moved forward and how the private sector is best harnessed to national objectives to get UHC to as many people as possible, as quickly as possible. So I recommend you read the report. Now, the chair of the team writing the report is Sir David Nicholson, who is right next to me. He's currently visiting professor at the Institute of Global Health Innovation at Imperial College in London. He's worn a host of other hats in public health, both in the UK and internationally. I won't go through them all, simply to say one of those hats, he was chief executive of the NHS, the English National Health Service, for 6 years or so, quite recently. So a huge reservoir of experience on the part of David, and he's going to address us in just a moment. Our other team members on the panel are, next to David, Isabel Tevissen, who is Vice President of Healthcare at DEG, which is an investment company which specializes in healthcare, based in Germany, I think, Isabel. So welcome to you. Next to Isabel is Rob Yates. Now, he is a long-time expert and specialist in public health systems. He is a senior fellow at Chatham House, the research institute in London. Next to Rob is Khaled Mohammed Al-Amadi, who is CEO here in Qatar of the Medicare Group and the Al Ahli Hospital. So brings a Qatari perspective. Khaled, welcome to you. Next to Khaled is Jeanette Vega, who is Chief Medical Innovation and Technology Officer at Red de Salud, the Catholic University healthcare provider in Chile, which Jeanette tells me is the biggest, most important, most respected private healthcare provider in Chile. And to keep up our South American contributions, on the end of our panel, at that end, give a warm welcome to Julio Mazzoleni, who is Minister of Health in Paraguay. So, ladies and gentlemen, give a very warm welcome to all of our panel. Now, the format is pretty simple. David is going to open things up with some observations, a quick sort of overview of the report, its objectives and its conclusions. So we'll hear from David first. I will then get a chance to get some insights from all of the panel. And then I'm delighted to say, and we've got a great crowd here, I'm delighted to say we're going to leave lots of time for you guys to ask specific questions, whatever your perspective, whatever you're bringing to this debate, whatever part of this debate you're involved with yourselves professionally, you'll get plenty of time to ask questions of the panel too. So that's the way it's going to work. So David, at this point, I will invite you to take to the lectern and make the opening remarks.
Okay, well, good morning, everybody. I'm David Nicholson. I had the privilege of chairing the forum. And as you can see, we had a remarkable array of talent in that forum. And I'd just like to begin by thanking both WISH, Qatar Foundation, for helping support this, for the people on the forum, for the enormous amount of work that they did, and particularly to John T. Rowland and his team at KPMG, who did a great job bringing all of the evidence information together in order to make the report what it is today. So thank you for all of that. And this is the second time I've chaired a forum for WISH. The first one 4 years ago was on universal health coverage, a policymaker's guide. And what we focused our attention on was the thing that everyone focuses their attention on, which is basically the financial system that underpins it. How do you do pooling? How do you organize yourself from a paying perspective for universal health coverage? And there's endless articles written about it, there's endless work done about it. We came to a number of conclusions about that, the importance of political will to enable it to happen, the importance of a predominantly publicly financed and governed healthcare system going forward, and the idea that when people started off, they should start to think about covering whole populations for particular things rather than sections of populations in order to make the idea of social solidarity, which underpins universal health coverage, a critical part of when you do it. And as I say, lots of work is done on this, and there is a broad consensus about how you might take it forward, although every country has to find their own road. There is no secret, no silver bullet that you can use in order to implement universal health coverage. But the things I talked about will make it more likely to deliver it. Now, if you look at this, the diagram we've got here, it was drawn up by Julio Frenk. It will be recognized by many of you here. It's it's a relatively straightforward idea about the importance of where issues lie in terms of the public and private sector. There is little argument about stewardship being absolutely the public responsibility, the responsibility of government. Next, finance, predominantly government finance, is going to make universal health coverage work. And at the bottom, healthcare products, there is consensus that the private sector best do that. The area of controversy has often been service provision. And one of the things that I can say, having done the literature search, looked around, this argument about whether public is better than private or private is better than public is almost entirely based on what people believe. There's little evidence, research evidence, that would show one was better than the other. But of course, everyone has their beliefs about that, and that's why it's so significant. Now, one of the things that we concluded after the last report was that we may get a wonderfully honed and organised financing system, but if there's no one there actually to deliver it, what do we do? And very little has been concentrated on how you create that delivery system, particularly one which inevitably will involve both the public and the private sector. And as Stephen said, many countries are going through this process. 130 countries have signed up to deliver universal health coverage for their populations by 2030. And they will all need not just a finely honed financial system, but actual service delivery on the ground for patients. And these countries are examples of countries that are making big decisions at the moment around national health insurance and the way they fund their systems, and all of them together, more than half of the healthcare that their patients currently receive is delivered by the private sector. So it's hard to imagine universal health coverage without a major role to be played by the private sector. And there is undoubtedly, country by country, and I guess this is, there's no country we've found yet where everything is perfectly aligned between the public and private sector. Some are doing more than others, but this alignment is absolutely critical. So if you think about the way the misalignment operates, and some of this will, I think, resonate with people in their own countries. You know, the payers say that what they want is highly standardized, large-scale health provision. They want innovative models of integrated preventative primary and secondary care. They want universal last-mile access, and they want skills to design and run high-quality, low-cost health services. That's what payers say that they want. And very often, what they say is the private sector provides overpriced islands of excellence or unreliable small-scale operators, episodic fee-for-service treatment, city-based care, skills to design and build world-class facilities are there. But you can see the misalignment. And what we are saying is that in order for universal health coverage to become a reality, you need to make sure that those things are more aligned. And we've done a big survey of private healthcare providers. You can see about how ready they are, how they're engaged in the universal health coverage argument. And what you can see out of that is about 25% to 30% of them are actually gearing themselves up to the future of universal health coverage. The majority are doing something, but a substantial proportion are doing nothing at all. And unless we can engage them more sensibly and work with them more effectively, we're not going to be able to deliver on the ground the ambitions that we might have for a healthcare system overall. And the public sector can do quite a lot to make this a reality. They can provide certainty to the private sector, they can provide clarity, they can improve trust. And one of the issues I think increasingly around is that if payers think they can construct ever more complex and clever payment systems in order to get the private sector to deliver a universal health coverage. It won't work. You need to build trust within the system. And in some countries, that trust is very, very broken down. An example of where trust is trying to be built is in Brazil, where they have a white book, where they have a deal between the public and the private sector about what was happening. But nevertheless, there are real issues here about what the public sector can do to make this a reality. We've looked at some really impressive examples of where private providers have engaged in that UHC process, who've started to develop their own approaches to all of this. You can see 4 of the examples, excellent examples that we have on there. There are more in the report. So at best, the private sector is really engaged, being innovative and taking this forward. And we have 3 basic practical recommendations that can be taken forward in relation to all of this. The first one is about investors. There's huge investment going on in healthcare and in the private sector through both sovereign funds, but also through the straight affect private sector. And we think that investors should work together to think about how they can contribute to universal health coverage, how they can work together to ensure that the great practice we've seen in some of those hospitals and service deliverers can work in the future, how we can think about investment packages which can reinforce and support primary care. In that way, the investors can play a constructive role in terms of many of the impact funds that they're responsible for, to ensure that not only can they make a return for their investors, but also that they can contribute to the global objective of delivering universal health coverage. In terms of behaviours, we think it would be good if countries could look towards some kind of mediation service, some kind of help to bring public and private sector together where trust is not great. We've seen that done effectively in 1 or 2 countries, and we think there should be more efforts to put that into place to enable and support people. And we need to design some tools to enable people to look at how ready their private sector is in their countries to enable this change to go forward. So they're the recommendations. They're practical. I have to say that the investors are having their first meeting this afternoon at WISH, which I think is a great step forward. We're committed to all of this happening because we genuinely believe that the way in which you can deliver universal health coverage for all of our people is by a sensible and organised partnership with the private sector. Thank you.
David, thank you very much. Right. Well, an extremely concise laying out there of what David thinks are the challenges and the opportunities that exist, utilizing the private sector in the best possible way. So let's open this up to a bit of a discussion. Isabel, I'll start with you. You are in Europe, but you're working with an investment fund looking at where there are opportunities, frankly, to make money out of healthcare provision, private healthcare provision. And David talked a great deal, I think he used the word trust 4 or 5 times in his presentation. Why should politicians and, more importantly, the public trust that the private sector, when it looks at investments in healthcare right now, is committed to signing on to the notion of UHC, is committed to reaching out to the poorer, the disadvantaged, to provide healthcare to them, rather than just seeking the quickest profits, which often appears to be in the sort of high-end, appealing to the upper middle class and the wealthy people who can afford to pay top dollar for top-notch service. Why should we trust that the private sector has a change of attitude going on? Yep, the microphones are available, so panel, don't fight over them, but share them generously.
Okay. Well, thank you very much. I think that there is a very good chance having digitalization and also the experience of India, how to reduce costs In the past, we said, okay, good technology is expensive, so we need good payers. But I think that nowadays, having the possibility of reducing costs, of making platforms, of engaging telemedicine, you can really differentiate between simple procedures and more complicated, so that the simple ones are done in a way to reduce costs, and the more difficult ones are really done by this very expensive, using this expensive technology. So you have to differentiate.
So when you're looking at healthcare providers, private sector healthcare providers around the world, are you seeing companies that now have a business model that allows them to believe they can, they can make money and please their shareholders and deliver low-cost, efficient primary care, for example, and care for, the sort of non-communicable diseases, sort of the boring but hugely important bits of healthcare, which in the past, the private sector hasn't really wanted to get too involved in because they don't see money to be made there?
Well, I think the very important issue is a cooperation between private and public. And I think it's a good thing if private companies want to earn money, if they deliver the right things. The issue would be, oh sorry, I lost
Well, I'm just wondering whether, for all of the fine talk about the need to get the private sector to deliver so much of the world's healthcare and reach the 1 billion that we want to see serviced by UHC over the next 5 years, whether in reality the private sector companies that you work with and talk to are much interested in primary care, for example, or the more boring, chronic, long-term bits of healthcare, which people need, but which aren't necessarily the easiest to extract quick profits from.
Yeah, well, I think private companies are interested in earning money and also in doing good. We also see that there is a lot of commitment, not only the issue of earning money, and they will do if they have the right payers. So I think from the public sector, the important thing is to have reliable payers. Even if the payment is not so high as contracting with a private insurance company, nevertheless, you need payers that pay in time with agreed fees that must be reasonable. And in this case, I think you will get a lot of private commitment.
Okay, well, Rob, I'm going to turn to you now. You look at healthcare provision around the world. You're obviously from a UK environment where we've all grown up with a national health service, free at the point of delivery to everybody, set up by the government, run by the government, although there's now obviously a significant amount of private sector involvement too. What's your take on this? Do you think that the mutual suspicion, the ideological gulf that there has been within healthcare between the notion of public provision and private provision, is the gulf sort of being reduced, and is the mutual suspicion dissolving?
Yes, I think there is, but I think it's understandable why there is that suspicion. I think we recognize the nature of healthcare. It is quite easy for providers to exploit people. I mean, there's this asymmetry of information between you as a consumer of services and you as a provider. And if you just let the free market run riot, you will undoubtedly have sort of charlatans giving people sort of fake treatments and exploiting them. So I think that we've recognized that to achieve universal health coverage, like the report explains, you need very, very strong governance from the state, and you need strong purchasing, and the financing predominantly being done in the public sector. And I think, this is a good thing about universal health coverage, that we are seeing this trend towards much more public financing and a recognition that you can only really achieve UHC where you have the state forcing healthy, wealthy people cross-subsidizing services for the sick and the poor. So it's undoubtedly the case that across the world, the trend is away from private voluntary financing to compulsory public financing out of general taxation. But that very much puts the onus on the state to become a better purchaser of health services, either from using their own services or using the private sector. And I think that we are recognizing in a number of situations that the private sector can have a very useful role. I think you're right that there is a concern that still too much of the attraction of the private sector is to the high-end hospitals, to the expensive stuff, which tends to be more profitable. And what we need to be encouraging is much more focus on cost-effective primary healthcare services.
Well, that's so important, because we have to keep remembering what we're really talking about, which is extending UHC to the hardest to reach people across the world. And so I want some case. Do you, and I'm going to ask the rest of the panel too, do you have case studies in mind? Can you persuade me that there is now a real reason to believe the private sector can be very actively involved in reaching those hard to reach people?
Yeah. There are, I admit, few and far between at the moment. And I think this is the challenge to the private sector. You know, we were involved in doing the report, and we were all sort of scratching our heads and saying, you know, where are the best examples at scale, the private sector engaging in cost-effective primary healthcare services? And there weren't many, to be perfectly honest.
So let's take India. We talked about India, and I don't know if there are Indians in the audience who can contribute later, but it's extraordinary, the figure, if I'm right, 80% of all healthcare in India is actually comes from the private sector. But how much, but the problem is that the poor in India get really rubbish access to healthcare, if any at all. So that 80% number isn't actually suggesting that the vast bulk of poor Indians are getting any health service at all.
Now, there is a very good example of India in the report, actually. You see on page 35, we draw attention to the Mahala clinics in Delhi, which are an attempt to get private doctors providing universal free health services to the poor. They're recruited on a sessional basis and are paid per patient seen. So it's using public facilities and public governance, but bringing in private doctors to run those who are trusted by the communities. And they're proving spectacularly successful. I think they've seen about 8 million people now. So there is sort of a public-private mix, getting private doctors in to work out of those hospitals, those health centres.
Yeah, good. Well, we'll come back and hear much more from you, Rob. But now, Khalid, here we sit in Qatar, by any measure, per capita, one of the wealthiest countries in the world. And we all know from the opening of the new Sidra facility you have amazing, top-notch, state-of-the-art, best-in-class private sector healthcare. But do you have a private sector which is also successfully reaching out into primary care, dealing with some of the chronic conditions that we see in Qatar, like diabetes? Is the private sector really addressing the needs in that particular health field? Try and persuade me that the private sector in Qatar really is engaging in all levels of healthcare for all levels of Qataris. Oh, and by the way, everybody, Khalid's going to speak in Arabic, so if you don't speak Arabic, get your headsets out.
أكبر تحدي يواجه القطاع الخاص في دولة قطر اليوم إنه الحكومة هي موفرة أقصى مستوى للرعاية الطبية. فبالتالي أي قطاع خاص يدخل في دولة قطر اليوم لابد أن يواكب هذا التحدي. لا شك أن اليوم القطاع الخاص في أي دولة من الدول هي تمثل مستوى صحي مهم ومميز في أي دولة كانت. لذلك لابد أن يكون دوره مكمل للقطاع الخاص العام، ودوره لابد أن يكون أيضا متمم لمستويات الصحة اللي تقدمها وزارة الصحة. يتطلب توفير هذه الأمور أن يكون في آليات للتوازن والتعادل بين القطاع الخاص والقطاع العام، بحيث أنها تحقق ما تستطيع أن يحققه الحكومة أو الدولة. بالتالي عندنا كثير اليوم من القطاع الخاص إذا ما توفرت له الإمكانيات العالية لا يستطيع أن يؤدي واجبه كما تقول بشكل متكامل، لأنه في أمور له مسموح يسمح له وفي أمور لا تسمح له. فبالتالي لدينا في المستشفى الأهلي نموذج مرن في تنفيذ الخدمات الصحية. تتميز خدماتنا بسرعة والسهولة توفيرها. لكن لا يعني ذلك أنني لست مؤسسة ربحية، فبالتالي الربح هنا بالنسبة لي هو يعطيني دافع للاستمرار. إذا لا يوجد هناك هامش ربح فبالتالي لا يوجد هناك استمرار. الربح أيضا يعطيني جزء آخر، يعطيني أني أنا أقدر أواكب وأطور نفسي مع الأجهزة الحديثة ومع التقنيات ومع أيضا تطوير الخدمة. الصعوبة في دول الخليج أو في قطر بالذات المستشفيات الخاصة أنها يجب أن تواكب اليوم القطاع العام. القطاع العام هنا أكبر منافس للقطاع الخاص في دولة قطر بحكم أنها دولة غنية ما شاء الله، وبالتالي فعلا هي موفرة العلاج بالجانب. الوضع يختلف اليوم إذا بنقارن بين دول نائية أو دول غنية. قد يكون متطلبات المستشفيات الخاصة في الدول الغنية تختلف، فيها رفاهية أكثر. أنا اليوم أسعى أن أحقق الكمال، وليس ولا هو الهدف عندي إني كدولة غنية إني أنا ألجأ إني أقدم العلاج الأساسي. اليوم العلاج الأساسي الدولة الحكومة تقدمه. مع ذلك المستشفى الأهلي يقدم جميع العلاجات ويقدم جميع الطب. عندنا كل التخصصات الموجودة في المستشفيات الحكومة بلا استثناء، ولكن في لنا حدود، فينا ليميتيشن، يعني ما نقدر ان فعلا نتخطاها وفق معايير معينه. هذه موضوع القطاع الخاص. المطلوب اليوم من القطاع الخاص في الدول الغنيه انها قد تلجا الى يعني نوع من التوازن والتعادل بين في الصلاحيات ان صح التعبير بين القطاع الحكومي والقطاع الخاص. الرؤيه مجملا هي راح تكون افضل للمريض وافضل للشخص المستفيد من هذه الخدمه، بحيث راح يكون فعلا تنافس قوي. في النهايه راح يصب هذا التنافس في مصلحه المواطن والمقيم في اي فرد في اي مجتمع كان.
All right. Let me ask you a very simple question. Do the wealthiest Qataris use the public system, or are they always seeking their treatment in the best private hospitals?
في قطر عندنا القطاع العام اليوم مطلوب جدا. يعني اليوم أنا أجي أتكلم على مستشفى حمد ما شاء الله من أروع الخدمات اللي موجودة فيها. نساء والولادة في أيضا تابعة لحمد من أروع الخدمات. عندنا سدرة، عندنا الرعاية الأولية، هذه أيضا كلها موجودة. ولكن اليوم القطاع الخاص في قطر يشتغل على أساس آخر، وهو توفير الوقت. اثنين، قد يلجأ له الشخص لوجود طبيب ستار موجود معه، طبيب مميز موجود معه. لكن خدمات القطاع الخاص اليوم هي لابد أن تواكب يعني خدمات الفندقية إن صح التعبير، لنستطيع أن نجلب الأغنياء على حسب سؤالك أو المواطن القطري أن يأتي للمستشفيات الخاصة بتوفير الراحة، بتوفير خدمة فندقية، بتوفير وقت بالنسبة له على أساس أنه ينجز أو يأخذ علاجه في أسرع وقت ممكن من غير قائمة انتظار.
Yeah, I understand. It just seems to me, and I'm going to move on to Jeanette now, it just seems to me, it's important when we're talking about weaving the private and the public interest and healthcare sectors together, that you don't end up with a sort of apartheid-style service and system where still, despite the fact that you're building capacity in the public sector, there's a sense that it's a real second-class service, and that if you have money and the wherewithal, you still opt out of that as quick as you can and go private, because that's where the real sort of quality and the safety and everything else exists. So in Chile, Jeanette, many of us in the room won't know so much about the way the Chilean system works, so give us a quick basic grasp of how the system in Chile works and whether you feel that you are successfully weaving together the public and private.
Well, in Chile, the system is very much alike to the UK system. So we have access to care free at the point of service. The only difference is that we fund the system not only based on general taxation, but based on social health insurance.
Right.
And then I think that I am the former director of the National Health Insurance that covers 80% of the population in Chile. And I think that universal health coverage is a huge opportunity for national health insurances. In fact, during my tenure, what we did is that we realized that we were very much the biggest influencers of the market. And we said, there is no system in the world that can be only publicly provided. So let's use this opportunity to really make the private system to work under public rules. And I just want to emphasize that the strategic lever to do that is in fact strategic purchasing. Because if you change the way that you purchase services to the private providers and you move from pay per service to pay per resolution of problems, you really can change the rules of the game. So what we did is that during my tenure, we tried to put out public tenders and to provide services to our affiliates, mostly using DRGs and then the equivalent in primary care. And then we were able to do basically, I would say, three things. First of all the private sector has to change the way they were providing services and introduce some efficiency in the way they did provide services. Because if not, given the type of funding, they would lose money. Second thing that happened is that they had to introduce information system. Because we, as a requirement, we said, okay, but we need to make sure that we do the claims electronically. And in order to do that, we need to introduce interoperability and introduce a common information system. So we forced the private sector to basically to give us the information. And then the third part that we did is that we basically say, okay, and we need to move to prevention. So we need to introduce a new way, and then we are going to be happy to pay for packages of care related to prevention.
Just a very simple question. What percentage of healthcare provision in Chile is in the hands of the private sector?
It depends. If we are talking about hospitalized care, it's 20%. If we're talking about primary care, for prevention, 80% public. For curative care, it's like 40% private.
And do you see that balance shifting in the future much more? So the percentage of private sector involvement is going to go up significantly?
Well, I have a bias. We hope no. But if it has to be, what we want to make sure is that the private sector follows the public rules.
Yes.
That's basically what it is.
Do you just think the Chilean public is alarmed at the thought of more and more of their healthcare system being put in private hands?
No. I mean, all over the world, what happens is that people believe that the private sector is better in general because basically they have better hospitality. But what happened in Chile, and I think that happened also in systems that have the same type that people for complex things go to the public, and for simple things go to the private.
Right. Okay. I mean, it's an interesting proposition that you think all over the world people basically think you get better healthcare in the private sector. Right?
Most of the world, I would say.
Well,
not all the world.
Well, there's something we'll open up very soon. But we're going to go to questions very soon, but before we do that, we just need to hear from Julio, our last contributor. Julio, I've got what sounds like a dumb question to you, but I think it's quite important. You're a government minister. When you have a health problem, a serious problem, you need to be sick. Where do you go? Do you go private or do you go in the States?
Yeah.
Yeah, that's a tough question. Yeah,
Well, it's actually a very simple question. Maybe it's a tough one to
Well,
answer, but it's a very
yeah.
simple one. What's the answer?
Well, up until 2.5 months ago, I was in my private office. So I'm in office since August 15th. So yes, I would have gone probably to the private sector, to be honest. Yes.
And now, and this is interesting politically, is there an onus on you, because you're a public figure now, accountable to your public? Is there a directive which says you as a minister should be seen to go to a public hospital?
I feel that way. There's not a directive, but I do feel that way. Yes.
You do?
Yeah. I came from the dark side of the force. You know what I mean?
So to my point about us needing across the world to get to a place where there isn't any sense that public healthcare is a second-class service, how close are you in your country to really delivering on that? So that, the ordinary, let's say a bus driver in Asuncion,
Yes.
who doesn't have a great deal of money, can really feel confident that if he's sick and needs hospital care, healthcare provision, that, even without money in the public sector, he's going to get basically as good quality care from specialists as you, Mr. Fancy Pants, in your private sector office or indeed in your government office.
Yeah, but first I have to describe you a little bit of how the system works to understand that, if you give me that. And we're in fact in a reform of our national health system. But to make it simple, we have a segmented and fragmented national health system where 70% of the population is under the public health with no contribution. Yeah. Then you have a 23% under the social security with a contribution. That would be the bus driver, hoping he's a formal employee. Yeah. He would get relatively good care, at least in the capital city and the region. And then you have a 7% approximately that goes to the private sector. So all of these subsectors are funded separately. So as you can see, we're very inefficient, both from a funding and from an operational standpoint. So that's our challenge, to change that. And that's why we're initiating a reform that's going to be tough. We also have a lot of problems with infrastructure. The offer of regular hospital beds, of ICU beds, of even primary care, it's about half of what it should be. So we definitely need the help of the private sector to fill that gap. And we have a good examples of cooperation and within the digital health information system, which is another area that we're also facing. Right now, the public health is paying for hospital beds when they're overpassed. And there are certain areas in the country, like the Paraguay and Chaco, where there's very difficult access, and there's a lot of natives that are dispersed in a large area. And in those areas, we have a few cities with regular good hospital facilities, and we're advancing on an agreement where the public health is gonna provide the primary health care, and then the complex medical issues are gonna be taken care by the private sector. I see over the next 10 or 20 years that the private contribution is gonna grow. But this is going to be...
Similar percentages ultimately to Chile, do you think, in terms of the balance between public and private? Because we heard that roughly...
Yeah, I think we're going to get close to probably to 20% or so. It's not cost effective for the public sector to build the hospitals we need. Although we are focusing on the primary health care, which should be our main interest, we can't deny what we need on that area. And I think the role of the private sector is just important. But it has to be under the umbrella of a new system, a new national health system, integrated. We're moving towards probably a single payment type of system, and definitely to make sure we have universal coverage and access.
So you need, when you're working with the private sector, you need to be really rigorous about the conditions you place, about the contracts that you give, and you guys are going to be held to account by your public for the
Absolutely.
way you handle that.
Absolutely, absolutely. And we need to make tax reforms and that kind of thing also.
Yeah.
There's a lot of challenges.
All right, I'm going to open it up, but I can just tell, Isabel, you want to say something. So grab your microphone and then we'll open it up.
I think I have to work a bit for the private sector at this stage. We finance, for example, in Turkey, these PPPs for hospitals, where we as a development company finance the borrower, private contractors that build the hospital,
Right.
they operate the hospital,
Yeah.
and then the Ministry of Health is in charge of the medical services. Sometimes procurement is done by the private, it depends on the arrangement. This is one way of cooperating, and we have in Mexico an integrated service provider, a private company, and it is his clients are IMSS and ISTE. This is the Social Security. There are contracts for 1 to 3 years, publicly tendered, and they provide services, technical services in the operation room, for example, in the case of minimal invasive technology, or in the case of radiology, etc. So there you have the public sector that has, in this case, has the premises, but not the technical knowledge and equipment, so they work together. And this is a model that is working, and I think in many other countries in Latin America, they are starting with these integrated services.
Does this work well, David, this notion of integration and even the private sector building facilities and all of that, in your experience?
Well, it can do. And there are examples of it doing really well and examples of it doing really
I can
badly.
think of a few of really bad ones, yeah.
I can think of 1 or 2 bad ones as well. So
what's the difference between the good ones and the bad ones, and what can we learn and therefore extrapolate into the future to make sure there are very few bad ones and lots of good ones?
I mean, part of the issue here is the public sector, the payer, being really clear about what the requirements are. And where it goes wrong is when they haven't thought it through properly and they end up with something they never wanted in the first place, or provide the private sector with the opportunities to get into areas that they didn't want to get into. And that's why it's critically important, it seems to me, for the payer in all of this to make sure that it identifies and specifies exactly what is required for the patients and the public. And when we try and short-circuit that, that's when it goes wrong.
Right. Okay. It's fascinating stuff, and I suspect there's some real experience on the floor which we ought to hear from. So I'm going to, oh great, there's loads of hands raised. All right, well, we'll do 2 at a time. So we'll start with the microphone on this side and get to these 2 gentlemen, and then we'll come over to you 2, or 3 of you on that side. But we'll start with these 2 just because they caught my eye. So stand up, sir, and we'll get the microphone to you. And then the gentleman behind you. Just tell us your name and give us a quick question.
Yes, my name is Rob Walters. I'm the past chairman of Orbis International. We are an NGO involved in healthcare, mostly in developing countries. And the point I want to raise is there was one issue here, there was one example of cross-subsidization from the private sector to the poor, and I would suggest that we should see a lot more of that. It's greatly in the interests of the private sector, of private health companies, to invest some of their profits in the poor within the countries they work. I think that will raise their profile, I think it will raise their respect, and it will greatly benefit those people who cannot at this point benefit from the healthcare that is available usually.
Yes, okay, good. Well, that's an important point, and we'll get the panel to think about that. And so, sir, behind you, you take the mic. Name and question.
Stephen Dorrell, a former health minister in the UK. I want to raise a question of cherry picking, but in a slightly unusual context, because I completely agree in the UK and indeed across the world as a whole, the issue is avoiding academic centres of overemphasis, not diminishing them, but avoiding overemphasis on academic hospital centres of excellence and promoting development of community services and prevention.
Yeah.
And the case of cherry picking I want to cite is the UK health and care system, where what we've seen through a growth of the budget over the last decade of around a quarter is that virtually all of that has gone to state-owned state-owned NHS hospitals, and virtually none of it has gone to the development of primary care in the health service, and in fact there's been a contraction of the resources available to social care in the UK. Doesn't that underline the importance of what David Nicholson was saying, is that the real aces with these questions are held by the state commissioners, and the requirement is to be clear what it is we want from providers, whether they're private or public, because both public and private sector providers can respond effectively to intelligent commissioning.
Right, okay. Well, two really interesting points there. So let's deal with, I can't remember who, was it you, Rob, talked about cross-subsidization quite explicitly, and the point being made is it is hugely important, and that the private sector needs to take on board its obligation to, if it's extracting profits, to then think about how it invests in reaching the poor and the disadvantaged.
Sure, and I think the most effective way that the private sector can really channel their profits and resources to the poor is through paying their taxes. You know, this is a word that often isn't used very much. In places like Davos, everyone talks about corporate responsibility, and wouldn't it be nice to help the poor once in a while? But really, the best way to do that is for big corporations not to put all their money overseas and not pay their taxes in the countries where they're operating, because that's where the big money is. Let's face it. And I think, absolutely, as Stephen Dorrell's saying, the state needs to put their money where their mouth is. Once we've raised these income taxes and corporate taxes and have this big pot of money, it's no good then as just like sort of shoveling it back into the corporate sector. It's got to be looking about saying, well, we do want to invest in district-level primary healthcare services.
But do you think Stephen Dorrell's right that let's not get too locked into talking about Britain, but it is an interesting example for most folks to look at how the NHS works. But he's suggesting that at the top level of sort of strategic thinking, there's been far too much. They've been too seduced by building more centres of excellence and the high-end tech-based treatment facilities, and not enough focus on getting out there with better primary care and social care and everything else.
And I think that's true, and I think that is a failing of governments, really, sort of not being accountable to their populations, so it's far too easy for the politicians in the capitals to want to improve services for them and their friends and, have centres of excellence that they can open in the capital city, and they never get out to the remote areas to help the people, and that it really is therefore on the onus of the population to demanding of their politicians that they spend their health resources better. And if I can just give you one example, you were asking for sort of bad examples about how things can go horribly wrong. It's one in Lesotho where really through donor pressure, the government was encouraged to sign up to build a complete PFI, private finance initiative hospital near the capital involving a South African company. And it's now taking over half the entire health budget. So the government is actually having to sort of scale back on district level HIV services to fund the contract for this hospital. So one has to be very, very careful. And there you can see it's the corporate interests, but also maybe the politicians rather naively signing up to this.
It's not easy being a health minister, Julio. Are you up to the job? Because you're going to have to make huge strategic decisions, and you're going to be very seduced by people bringing you plans for a fancy new hospital in Asuncion. It's going to look great. You can imagine cutting the ribbon. Yeah. You're going to, it'll all be over the TV news. It'll look fantastic. Yeah. But you shouldn't be seduced by that.
Yeah. Thank God I'm not a politician, although I'm in a political
you are now.
role. Yes, in a sense I am. But we have crystal clear what we need to do. And although I've been talking about hospitals and our lack of infrastructure, primary care is definitely where we're heading all of our efforts.
Really?
The problem is as I say usually, we are like a car that needs to change tires in motion. We need to basically address all of it, but we know exactly where we have to put most of our
And you're confident that in your country, the private sector can be brought on board for that aspect of what you need to change?
Yes, I think they're more attracted certainly to high complex hospitals and whatever there's money. But we actually have some initiatives that we're doing not only with the private health subsector, but even with transversely with other economic groups. Like we're working, for instance, with supermarkets where we put these units of health promotion and prevention.
Right.
So those kind of creative initiatives where we can work with other sectors, not even health private sectors. So
okay. I want to get as many questions as we can. So I promised there's 3 women over here who've all got enthusiastic hands up. So we'll get to all 3 of you. I don't know who wants to go first. Let's say you, ma'am, in the front. Yep, and then we'll get to you two. Don't worry.
Yes, thank you. I'm Pradnya Haldipur. I'm with Children's National Medical Center in Washington, D.C. I have a question, actually, which is, do you find that in the pediatric space, the potential gap or potential synergies between the public and private sector increase or decrease, given the relative lack of profitability in the pediatric space?
Right, yeah, all right. We'll hold that one, pediatrics and how it's working out with public-private cooperation, and then we'll get to the next one, yeah.
Good morning, my name is Duha Hamdani, I'm from Ministry of Public Health, Qatar. My question is to Mr. Khalid. Mainly my question is how can we share experience, Qatar experience of the private sector, not just delivering a high standard quality of care, but being a partner with the ministry and the private and public sector in focusing on the healthcare quality, promoting best care, sponsoring some of the conferences, some of the events, which is not bringing money to private sector. Actually, you are paying for this. How can you share this great experience of Qatar? Thank you.
Okay, so that one's for Khalid, but let's start with I don't know who on the panel would like to talk about the degree to which pediatrics is or is not benefiting from involvement of the private sector, whether the private sector is not very good at You may. Yeah. Indeed you may.
Only we have in Eastern Europe, we have a hospital we are analyzing nowadays, and in the discussion of getting a hospital license, the Ministry of Health said, okay, you can do what you want, more or less, but please, 20% of the beds for the private supplier have to be for pediatrics and mother care. So this is a way to
That's written into the contract,
yeah,
the license.
Into the license.
License, yeah. And that was acceptable. I mean, that project is ongoing.
It's working, yeah.
Where was that? Which country was that?
It's in Georgia.
In Georgia?
Yeah.
Okay, interesting.
But we're not already, it's a plan for a hospital. It's not.
But is it true that pediatrics is one of those areas that the private sector doesn't really seem very interested in?
Again, I think there will be some services that will prove very profitable, and you sort of so you can imagine, say, around childhood oncology services and things like that, there'll be lots of money, lots of charitable money, so the private sector will be interested, and things like orthodontics and stuff like that, wealthy kids getting their teeth straightened out, sort of a lot of money will go into that. The challenge again is for the state to put the money into preventive and promotive services, and things like mental health services for children and adolescents, which does tend to be grossly underfunded.
Yeah, go on, David.
I think it's a really important issue because although, I mean, there is little evidence around that the private sector have embraced paediatrics and services for children generally. And partly it's because of the things that Rob has said. And it's partly because of the issue of scale. But it seems to me that particularly in some areas, and the example I would give you is child and adolescent mental health services. That is an area which is not well developed around the world generally. And actually the private sector, in terms of innovation and digital and all sorts of things, could do all sorts of exciting and interesting things, but they don't. And what I would say is that this is a challenge for the investment community, is if they could seek out places and people that can do that, I think that would be fantastic, and it's a challenge for payers to be able to articulate what these services might look like in the future.
Is there much mileage in issuing these licenses where you insist that they do certain things they don't want to do as a payback for allowing them to do lots of things they do want to do?
I think there is, but I think the best way to do this is by working with the private sector cooperatively. And an example I would give you is in Pakistan, where they recently signed an accord between the public and the private sector, where every private hospital with more than 100 beds has to provide 20 beds for the poorest of the population, every private hospital.
Right.
And that's done cooperatively and organised in a way. I think if the state gets into a very hard line on this, I think the private sector will always find a way around.
But it's a bit like...
But doing cooperatively.
Is that good? I mean, it's a very interesting idea, but, you know, we in London are very well aware, that there are all sorts of housing issues in London, and there's been an effort to enforce a rule that a developer developing a fancy new tower block has to allocate a certain percentage of the apartments in the new tower block to what's called affordable housing. But the developers get around this by creating a little annex at the back with no views and a separate doorway and a really crummy, frankly, space apartments for the affordable housing, while the rich people enjoy the views and everything else that goes with the main apartment building. Basically, they find loopholes and ways around it. Is that not going to happen in your vision of this?
Well, the point I'd make in all of that is possible. And that's why what I say is that some kind of accord, some kind of deal with the two sides is a much better, working cooperatively to do it, is a much better way of making sure that happens.
Right.
Trying to implement it irrespective of what people think is always very difficult. And all I'm saying is that we should try these out, people should work them through, we should see how they work to enable us to improve the situation.
All right, I'm going to stop you because, Khaled, you need to respond to the lady who was actually asking you whether there was real evidence that in Qatar that the private sector is working on things beyond the fancy hospitals in preventive work and primary work. I think I'm right in saying you weren't convinced. Am I right? You're not Oh, you are convinced? Okay. So it was rather than a critical voice, it was an invitation for you to share exactly what good work you do, utilizing the private sector in these perhaps less heralded parts of the healthcare system.
طيب احنا في القطاع الخاص المستشفى الأهلي يعتبر هو شركة مساهمة لستد في البورصة، لها مجلس إدارة وجمعية عمومية. كل سنة للمستشفى الأهلي يخصص جزء من الأرباح في علاج ذوي الدخل المحدود أو الأسر الضعيفة. يتم التنسيق في هذا الموضوع عن طريق الجمعيات الخيرية الموجودة في قطر، وأيضا لا نمانع إن كانت في أيضا حالات خارج قطر أن يتم علاجها من ضمن هذا المبلغ المخصص من الجمعية العمومية للمستشفى سنويا. أيضا المستشفى الأهلي عنده مشاركات دورية وشهرية لكل حدث وفق مثلا جدول منظمة الصحة العالمية اللي هي ينشر فيها التوعية من خلال مثلا يوم السكر ولا يوم القلب أو السرطان أو الأمور هذه. اثنين، احنا أيضا نساهم ونشارك بشكل مستمر بشكل أسبوعي، قد يكون لنا تواجد اجتماعي في مدارس للأطفال وهي الهدف منها، وأيضا في الأماكن العامة الهدف منها هي نشر التوعية الصحية لإيماننا بأن اليوم الوقاية من المرض هي أقل تكلفة من الصحة. الفكرة فيها أن احنا اليوم أيضا لنا دور اجتماعي ما ننكره ولا نتهرب منه. الحمد لله دولة قطر كمستشفى احنا ما علينا ضرائب مباشرة ان اليوم نحن ندفعها، ولكن لنا التزامات اجتماعية ما نغفل عنها وملتزمين بها، وبالعكس يعني نؤديها ونحن فخورين ونؤديها ونحن نعرف أنه هذا حق على المستشفى بكل رحابة صدر وبكل سعة. لذلك عندنا انتشار في هذا المجال كبير صراحة.
Good. All right. Well, that's important to know, and thank you for that, Khalid. I know there are lots more questions on the floor. Oh my goodness, there are lots. So, ma'am, you've got the mic, so you give us the next one, then we'll go over there.
Hello, I'm from Georgia. In my country, the medical sector is mostly privatized. More than 85% of hospitals and even in primary healthcare settings are private in Georgia. Right. And in these conditions, we have the universal health coverage. To be honest, it's not easy to work in this situation with the private sector, which is mostly oriented on the profit. But we went through this selective contracting under UHC to enhance the competition between the medical institutions, because if we buy both the bed and the good quality of care, so we received a bad and good quality of care. So we decided to buy only the good quality of care. That selective contracting is this key issue in this direction. The good informational system, the electronic medical records, which is our main challenge just now that we are working on this direction, and good informational system is our priorities in this direction. And the second issue is how to involve this private sector in the preventive medicine, because it's mostly important issue, and prevention is not so profitable for the private sector.
Well, can I stop there? That's a great question, because here you have a country which is committed to UHC, but in the real world, 85% of its healthcare facilities are in private hands. So how can the government best shape the environment, whether you call it the regulatory environment, the governance environment, to make sure that, you know, that private sector healthcare evolves in a way much more toward preventive care, much more toward primary care, much more what the government's vision of a good healthcare system should be, although the government isn't running the healthcare system, the private sector is. How difficult is it to marry those different aspects?
It is perfectly feasible, actually, and that there are some very good examples of some countries where most of the providers, vast majority of providers, are private, but the government manages to get them to do what society needs. A very good example is Japan. The Japanese health system is very good. It's held up as a very successful UHC model, and pretty much all the hospitals and doctors are in the private sector. But it's got a very, very strong purchasing function, and every 2 years they sort of bring all the private sector together and they have some negotiations, and these are really tough negotiations, and they bring prices down for some things, you know, like CT scans. You know, they'll say, right, competition is now such and technology is such that we're going to reduce the tariffs on these. And then with the savings, they then plough it into more promotion and prevention as well. So it can be done, but it really does mean sort of beefing up the purchasing and giving incentives and you know, extra funding to the practitioners to do more preventive stuff. As interesting is the case in the UK. I mean, you might say that our GP practices operate as independent practitioners. Most people in the UK don't really realise that or understand that they are private businesses, but they're so tightly regulated. And then the GP contracts that have been renegotiated in the last 20 years provide big incentives for doctors to do more on promotion and prevention. It's been very successful.
But there is something fundamental about healthcare which makes it difficult. Oh, I'm sorry, Jeanette. You go ahead, and then I'll air my thought.
Yeah, I think that it can be done, but it requires good governance.
Yeah.
And that is fundamental, because the issue is that in those particular contexts, usually the governance mechanisms are not necessarily there. I mean, unfortunately, there is a connection between marketization and decreasing government governance. So in theory, it can be done, very difficult. So I mean, I have mixed feelings. I think that in order to really be able to to work with the private sector, you have to have a strong public sector. It's a must. Because if not, basically, you don't have any leverage.
That's a very good point, yeah. But what do you do? I mean, you know, these are private, we're talking about private businesses. I'm just trying to get my head around, you know, the government wants to reshape the system, it wants to reprioritize, it tells a particular private healthcare company that's a key player in their national market, we need you to adapt, we need you to do different things, and here's a contract or for the future which is going to be renegotiated. And the private businesses, we don't like that. That's crap. We can't make money on that basis. We're pulling out. I mean, you know, because they say our shareholders will not stand for us signing this contract because we're going to lose money hand over fist. We're not interested. Doesn't fit our strategic vision. We're getting out. Then you've got a huge problem because they filled a big hole in your healthcare provision and suddenly they say they don't want to do it anymore. Then what do you do? Pregnant pause while we get a microphone. Yeah,
sorry, no, I mean, I think you make a really good point there, and actually, in practice, most countries who are in this are going to face this over the next few years. Because one of the things in the report I didn't say was that there's going to be a breakdown of the business model of many of the private providers. So many of these private providers that exist at the moment in low-income and developing countries rely on out-of-pocket payments from individuals for quite a lot of their income. And all the evidence shows that over the next 20 or 30 years, one way or another, that is going to move away from individual payments to social health insurance and taxation funding. So all of their business models that they had in the past are going to go. And there's some really good examples. So in Indonesia, when the national health insurance was established, the private providers said, we're not playing. You're not going to pay us enough.
Right.
And in fact, it happened in the UK when we introduced what were they called, ISTCs, when we wanted to introduce the private sector. We said to the private sector, we want you to provide healthcare at a particular price going forward. And they said, we're not interested. The Indonesian private sector said, we're not interested. The Indonesian private sector relatively rapidly came back when they realized that the government was serious and weren't going to back off. And so now all of the Indonesian private sector are now engaged in it. And in the NHS, similarly, all of the private sector, after about 18 months of I say whining and complaining. I don't mean that in a pejorative sense.
Is there any other sense?
They all came back as well. So if you can
so
demonstrate...
It's a game of chicken. You're saying it's a very high-stakes game of chicken.
It's not chicken because, I mean, if the government is ridiculous and says ludicrous prices that you can't deliver for, then it is in that sense. But if you're sensible and you've got a rational way of describing the way you're pricing, the way you're funding, and the most importantly for the private sector, the kind of guarantee of future work, the certainty, then you can get a proper negotiation going on. But it has to be done on the basis of trust.
Yeah, we're back to trust. Okay, I'm going to go, I'm sorry, Mr. Microphone Man, but I feel a duty to get voices from the back. And there's a lady at the back, and then we'll get the gentleman in the blue shirt on this side. I think these might be our last two questions. Can the microphone go to the... Sir, could you stand up so she can see you? Yeah. Right, but we'll start with you, ma'am. Go on.
Thank you. Elise Pedrana from the Burnett Institute. I worked in Indonesia for a number of years, and I'm glad you brought up that example. The private sector has entered the market well and truly, and what they're having an issue there is now that the private sector is employing a lot of the same providers working in the public sector. They now work across both sectors. And what happens is it contributes to absenteeism in the public sector because they're not getting paid enough. I wonder if you have any thought about ways that we can really try and address that particular issue. And the other issue is around reporting and transparency and accountability in the private sector. Often Indonesia struggled to be able to report on indicators of maternal child health within the private sector, and that is only going to become a bigger issue as this goes on.
Okay, who wants to take that on? Interesting question. Go on, Rob. And then we'll come to you, so then we have to wrap, unfortunately. But
Yes, the Indonesian question, it's very straightforward, the problem in Indonesia. The government's not putting enough money into the health system. I mean, if you look, it's flatlining at about 1.2, 1.5% of GDP in public health financing, and you just can't afford UHC on that. So the population have no choice but to use the private sector. Were the government to put more money into the system, pay its health workers more, you'd deal with that problem overnight.
Okay, I'm going to be quick because we're almost out of time, and I did promise the last question to you, sir.
Kinmaru, a physician epidemiologist at Mount Sinai School of Medicine. My question is about the role of the nonprofit private sector. The report and this discussion is really centered on the private for-profit sector. Both as an American physician, where in our country 60% of the providers are nonprofit, particularly when we think about promotion preventive services, the 1,200 federally qualified community health centers. And in my work in Nepal, over the last decade, as an integrated care provider, working with an integrated care provider in the public sector, I really don't see there being any viable opportunity for the for-profit private sector in the Nepal case to work with the government on universal health coverage, but I do see a strong role for nonprofit providers in that context.
Right, yeah, it's true. We haven't really gone into the difference between for-profit and non-profit private sector. Is the non-profit private sector a really important part of this conversation?
Yes, I think so. They normally work in the same way, more or less, as the for-profit, because they need to have profits to invest and to improve equipment, etc. So they probably are more directed to primary health. Right. But nevertheless, you have, for example, in Brazil, you have these hospitals of excellence. These are not-for-profit hospitals doing a good business. JCI accredited, and they are working together with the government. They are managing hospitals, public hospitals, so they are doing in this.
But is the questioner right that there are countries, I guess less developed countries, where the for-profit private sector probably isn't going to be very interested, but the not-for-profits might well be because of their mission statements and their general sort of view of what's important in the world?
Yes, you have a lot of not-for-profit in many countries working in parallel with the for-profit.
Okay, I've got a sign in front of me saying 0 minutes, which is a pretty clear indication that we've run out of time. I know there are still questions on the floor. I'm really sorry, as ever, I have to apologize as chairman that I haven't managed to get all the questions out into the open. But I know we all have more panels to go to and people to network with and meetings to attend. So I think I have to draw this one to a close, but I can't do that without asking and inviting you all to give a very warm thank you to all of our panel. So panel, thank you very much indeed.